Hey all, welcome back to the Real Life Pharmacology Podcast. I'm your host, pharmacist Eric Christensen. Thank you so much for listening today. Today I'm going to cover P2Y12 inhibitors. But before we do that, I want to make sure to tell you to go check out reallifepharmacology.com. Get your free 31-page PDF on the top 200 drugs. It's a great study guide, great refresher, whether you're taking board exams or out in practice. Definitely a no-brainer to go snag that. Simply an email will get you access to that. All right, so let's get into the class of drugs I wanted to cover. Talking about P2Y12 inhibitors, some of the more common test prep pearls, as well as things that come up in practice. So this class, the meds I'm really going to focus on are Clopidogrel, brand name Plavix, Prasugrel, brand name Effient, and Ticagrelor, brand name Brilinta. There is Cangrelor as well. That is an IV-only option in PCI associated with ACS, but not going to probably talk about that one too much. I'll focus more so on the oral ambulatory care type medications. All right, so let's talk a little bit about mechanisms and platelets. And so this class is an antiplatelet class, category of agents. So the P2Y12 receptor, when that's activated, it stabilizes and causes platelet aggregation. And so by using a P2Y12 inhibitor, we ultimately prevent that from happening, and we cause platelets to not aggregate and essentially thin the blood a little bit. A little bit more detail here. Adenosine diphosphate binds to P2Y12, and this actually increases cyclic AMP, decreases cyclic AMP when that happens, and lower cyclic AMP promotes platelet activation. Okay, so again, we're blocking this process from happening, and so we're going to cause the opposite, and we're going to cause platelet inhibition. All right, so talking about usages, I alluded to them a little bit. So ACS, PCI. So ACS is acute coronary syndromes, more commonly stated as a heart attack, for example, or an MI, myocardial infarction. Those are types of acute coronary syndromes. PCI is percutaneous intervention. Typically, stenting is done with that process as well. And that is, I would say, by a pretty significant amount is the most common situation you're going to see these agents utilized, and often they're used in combination with aspirin, dual antiplatelet therapy, or DAPT or DAPT. You may see that abbreviated as. Other situations you may see these antiplatelet medications used, the P2Y12 inhibitors, peripheral arterial disease, as well as potentially secondary stroke prevention. All right, let's get into the specifics on each medication. So first, Clopidogrel, brand name Plavix. This is a prodrug, so that is unique to Clopidogrel, and it is activated by CYP2C19. You're going to want to remember that one for sure. That's definitely a common test question, pharmacology question for sure. So Clopidogrel is activated by the CYP enzyme 2C19. Good one to remember there. Now, this can cause complications. So drug interactions I'll talk about later, but drugs that inhibit or induce CYP2C19 can affect Clopidogrel. Okay, again, I'll talk about that further on in the drug interaction section. One other thing that we're seeing more in practice and over the years of my time as being a pharmacist is assessment of genetic metabolism, basically. So if you've got a patient that is CYP2C19 poor metabolizer, they are going to convert less of the Clopidogrel to the active form, and that drug may be less effective than we would like it to be. So that is something you will potentially see in practice as well with Clopidogrel. The one other thing that maybe differentiates Clopidogrel from Ticagrelor, which Ticagrelor is getting a lot more use now as well, it is once daily dosing, so that can be a nice thing for some patients. And then in addition to that, it is generally less expensive when we just compare the cash price to some of the other agents. So less expensive, once daily dosing are a couple of big advantages there. All right, moving on to Prasugrel. This is also a prodrug. Again, brand name Effient here. This is also a prodrug, but it is not really activated by CYP enzymes, and so it's less dependent with some of these CYP interactions and things like that. So not generally as big a deal as Clopidogrel when it comes to the activation of that prodrug. It tends to be a little bit more potent than Clopidogrel, which, in a good sense, I guess, you maybe get a little bit more blood thinning effect, but, in a bad sense, you get more blood thinning effect, so that could put your patient at a little bit higher risk of bleed. All right, I've seen this tested before. Absolutely good thing to remember. Prasugrel is contraindicated if a patient has a history of stroke or TIA. Okay, very, very important to remember that. There's also cautions or precautions with patients who are older, so above the age of 75. Also, low-weight patients may be at risk for complications and increased bleed risk from this medication as well. So, few important things there to remember with Prasugrel, and because of the contraindication in stroke and TIA, and because of the maybe higher risks as patients get older, I would say I probably see less Prasugrel. Advantage of this medication potentially over, let's say, Ticagrelor is it does have once daily dosing. All right, moving on to Ticagrelor, brand name Brilinta. This is not a prodrug, so the drug has activity. It is a little bit different in a couple of ways. So one is it causes reversible platelet inhibition. The other agents in this class are more irreversible platelet inhibition. A little quicker onset, offset, which you could probably anticipate because there is twice daily dosing with this medication. So if you got patients that struggle with adherence and taking meds twice in the day, maybe they got a really busy schedule or something, we got to remember that with Ticagrelor, because obviously it's a pretty important medication to, prevent future episodes of heart attack, for example. One potential unique adverse effect I have seen reported, I haven't seen it much in practice, but I definitely am aware of it, is dyspnea. So kind of some difficulty or trouble breathing a little bit there. And then the other thing that definitely will show up on board exams, pharmacology exams, or certainly can, is there is a boxed warning with aspirin dose maintenance. So if we're using Ticagrelor in combination with aspirin maintenance doses should not exceed 100 milligrams. So what you're going to see with Ticagrelor typically is that aspirin 81 milligrams is going to be given with this medication if we're using dual antiplatelet therapy. Cangrelor, just briefly, it's an IV agent, rapid onset, offset, used obviously in a hospital healthcare type setting, used in PCI with stenting potentially when oral therapy is not feasible or not practical. All right, so guideline considerations. I did want to mention this because historically I saw a lot more Clopidogrel used, but now with Ticagrelor coming along, from an efficacy standpoint, guidelines do prefer Ticagrelor or potentially Prasugrel. I would say I probably see less Prasugrel because of that, the age precaution as well as the prior stroke TIA risk there as well. So definitely am seeing a little bit more Ticagrelor in practice at this point. So again, it is preferred in ACS with PCI, and that's per the American College of Cardiology, so ACC guidelines there. All right, so duration of therapy, did want to mention that with dual antiplatelet therapy. After acute coronary syndrome, MI, those type of things happening, usually it's going to be 12 months with the caveat of that's kind of a good reassessment point of, do we continue this longer? Are they at high risk? Are they tolerating it? Those type of things. So many clinicians will look to reassess ongoing use. Typically, it's going to be a cardiologist, but maybe a primary care provider as well, depending upon the situation and that sort of thing. So 12 months usually for that dual antiplatelet therapy. We're using a P2Y12 inhibitor with aspirin, then that gets reassessed. Now, if we've got bleeding risk situations, so let's say the patient had a significant, say they're 2 months in, 4 months in, 6 months in of dual antiplatelet therapy, and now they had, a significant GI bleed that, caused hospitalization. Obviously, then we're going to do, a risk versus benefit type of assessment in that situation. So, important to remember to, treat patients clinically, obviously, as well. Adverse effect profile, I think that's probably pretty straightforward. Bleeding risk, I don't really see a ton of other adverse effects in practice with these agents. Just got to watch out for bleeding, bruising, GI bleed risk, even things like intracranial hemorrhage, those type of things that can definitely happen. All right, let's take a quick break from our sponsor and we'll wrap up with drug interactions. If you're in the market for any pharmacist board certification study materials like BCPS, ambulatory care, NAPLEX, BCMTMS, geriatrics, go check out meded101.com/store. We've helped thousands of pharmacists and pharmacy students pass their board exam and can absolutely help you too. So again, go check that out, meded101.com/store. In addition, if you're a pharmacy technician, nursing student, we've got tons of other resources on pharmacology, medication safety, medication education. So again, check out all those links to Amazon books, Audible books, review courses. All those links can be found at meded101.com/store. All right, let's talk drug interaction. So first and foremost, I'm thinking about bleed risk with all of these agents. So any type of anticoagulation, any additional aspirin that the patient is taking and maybe they didn't report it to you or whatever the case may be. Even medications like SSRIs might have some mild antiplatelet type activity and could enhance that bleed risk. These are all things I'm looking for, particularly if you've got a patient that's reporting low hemoglobin, or we're seeing that on labs and they're reporting, bruising or nosebleeds that won't stop, those type of things. We really, really got to pay attention to that. The one, really, really big over-the-counter thing that I would strongly encourage you to pay attention to is asking about ibuprofen, naproxen, so NSAID use. These can interfere with the actions of platelets, increase the risk for bleeding in general, and then the GI toxicity nature, adverse effect nature of these medications can increase the risk for GI bleed as well. So really, really important from a class standpoint with the P2Y12 inhibitors to pay attention to these other medications that can increase the risk of bleeding. All right, I alluded to Clopidogrel and the CYP2C19 action. So again, Clopidogrel is a prodrug that requires activation by this enzyme, CYP2C19. So when we use medications that are inhibitors of CYP2C19, so these are drugs that are going to block the action of CYP2C19, that's going to potentially reduce the efficacy of Clopidogrel. It's going to reduce the effect of Clopidogrel. So that puts them more at risk for, let's say, another heart attack, for example. Now, what medications inhibit CYP2C19? The biggest and most important example that you should probably be aware of is some of the PPIs, particularly omeprazole and esomeprazole have the highest incidence, or maybe are used most commonly as well, for inhibiting CYP2C19. So in general, if we have to use a proton pump inhibitor, we're typically going to prefer pantoprazole. It's got less action on that CYP2C19 enzyme. So that's something that we're going to think about there for sure. Another option, we can look at other medications for, GERD, peptic ulcer disease, whatever we're trying to treat or prevent. We may look at an H2 blocker, for example, like famotidine. So we do have other options and alternatives out there if we're concerned about this drug interaction with Clopidogrel. But I think it is a good one, definitely be aware of, and something you could for certain be tested on. All right, so Ticagrelor, this again is the twice daily P2Y12 inhibitor. It can be affected by CYP3A4 drugs. So specifically, CYP3A4 inhibitors can increase drug levels and obviously increase the risk for bleeding. Classic examples are some of the azole antifungals like ketoconazole. We can have some of the macrolides like clarithromycin, HIV agents sometimes like ritonavir. These are all medications that can inhibit CYP3A4, increase the risk for bleeding associated with Ticagrelor. It's recommended to avoid strong CYP3A4 inducers as well. So these medications will actually cause Ticagrelor to be chewed up quicker, and we will have reduced levels of the drug and reduced efficacy. The medication won't work as well in preventing another heart attack, for example. So examples here, rifampin, carbamazepine, phenytoin, these are classic enzyme inducers that basically chew up the drug more quickly or stimulate enzymes to chew up that drug more quickly. And obviously, specifically here, we're talking about CYP3A4 with Ticagrelor. And then I do want to mention, again, emphasize the aspirin dose interaction. So again, maintenance doses of aspirin with Ticagrelor above 100 milligrams daily actually reduce the effectiveness of Ticagrelor. Okay, so this is why low-dose aspirin is recommended in combination with Ticagrelor. So again, 75 to 100 milligrams. Typically, we're going to be using baby aspirin, 81 milligrams daily there. All right, and then Prasugrel, wrapping this up, we don't have the CYP concerns with Prasugrel. So that is definitely a nice thing compared to Ticagrelor and Clopidogrel. All right, well, that's going to wrap up the podcast for today. Thank you so much for listening. Hopefully you picked up a few practice pearls. Hopefully it's helping you with your exam prep. If you like this episode, if you found it helpful, please do me a huge favor. Leave a rating review on iTunes or wherever you're listening. If you want to track me down, comments, suggestions, questions about study materials, books, things like that, don't hesitate to reach out. mededucation101@gmail.com. Feel free to track me down there, or feel free to connect with me on LinkedIn as well. Eric Christensen, PharmD, BCPS, BCGP. With that said, please support the sponsor, meded101.com/store, and I will catch you next episode. Thanks so much for listening. Take care. Have a great rest of your day.